Within this lecture, we are going to be discussing infectious diseases that are involving the skin and the eyes. So the PowerPoint here is from Chapter 16 from your resource, your textbook, and we'll go ahead and get started on this now. So when we're thinking about the skin, and we know it's our first line of defense that we have against microorganisms that have the potential to cause pathogenic diseases for us. We know the skin has lots of built-in natural defenses that it includes layers, multiple layers in the epidermis that are going to be protective, and then with millions of cells that actually are sloughing off each day, and those cells are being replaced. So in the epidermis, we know that we have epithelial tissue that are predominantly keratinocytes that are producing keratin that waterproofs us, seals, the water that's within our system, and then also have antimicrobial properties. So your entire epidermis, which has 5 layers in the thick skin, is completely replaced within about 40 days, typically. Again, the protein that is so protective for us is called keratin. It is produced by very special cells called keratinocytes, and these multiple layers are actually of the dermis too, are all protective for us. So we learned a lot about this skin in the anatomy and physiology, which most of you all have had. And this beginning goes a little bit over the anatomy so that you see, but the defenses and the chemicals we'll go ahead and touch on. Antimicrobial proteins that are being produced by our normal microorganisms that live in and on our skin that are competing with potential pathogens are very important to keep the skin healthy. We produce sebum, which is another word for oil. Again, this is going to make it so that potential pathogens will be discouraged from proliferating in the skin. We have sweat that also is highly salty, so that salt concentration can discourage microbial growth. And then we also produce enzymes called lysosomes that are digestive, that actually help to break down the cell walls of certain bacteria. So all of these things are causing our skin to be important to us as far as a protective mechanism that we're born with. So as long as the skin is healthy, as long as the skin is kept, clean enough, that actually can be too clean, really, that would dry it out. But anyway, it needs to be just right. Then we have lots of built-in defenses that are natural, part of our skin cells that are producing these substances, but also the microorganisms. And these are all part of your normal biota, the microbiomes that comprise all of those microorganisms that actually are keeping your skin in a state of balance. So if any of these get out of balance, then they have the potential or the opportunity to cause disease and become opportunistic pathogens. But as long as the balance is there, then the skin can remain healthy. So this is a little bit of a quick review of the normal structure of skin, and we understand that everyone has their own unique microbiomes that are studied, and it's changing all the time depending on the environment and the overall health of the individual. But we do understand that many of the diseases that we see of the skin are because of opportunistic pathogens. Microbes that can be part of the normal microbiome, but when the skin is insulted or the person's immune system is compromised, something can change that situation, and then those organisms actually start to overgrow and become opportunistic pathogens. MRSA is one that we talk about very early on in microbiology. So here it is again, and it's one that we commonly see. Staphylococcus aureus is the genus Staphylococcus aureus species. This is present in most people at any given time as part of their microbiomes, but we need it in very low numbers. So we understand that if the skin is too dry or cracked or if there are any lesions that occur because of trauma or any other situations, then Staphylococcus aureus can definitely start to overgrow, and then it produces some of its very virulent factors that can cause serious damage to the skin and can even become systemic and even a life-threatening infection if not treated. So it is something to definitely be concerned about, especially the Staphylococcus aureus that is resistant to many of the antibiotics that we have today, MR standing for methicillin-resistant Staphylococcus aureus. Staph aureus infections on the skin causes a lesion that is very, really kind of diagnostic when you see this type of lesion. So you can actually see that there's pus forming. Pus is actually a mixture of the fluids from the skin and tissues along with white blood cells that have come to the site to fight off the infection. And typically you see this red swollen area with white pus pockets, and it's fairly diagnostic. Now certainly we can culture it really easily or do a gram stain from this pustule region, and you would see the typical Staph aureus, which is a bacterium. So these clusters of round looking gram positive purple looking bacteria, and the gram stain would be very indicative of that, and then the culture would confirm it. So it's important that people that do have these types of lesions caused from Staph aureus, that they are very careful, that they are going to keep them covered to avoid transmission, because certainly not only can you transmit it to different areas of your own body if you have it, but it's also, it can be transmitted to other people. This is why, we would never want to share things like razors or those types of things, because it can definitely be transmitted that particular way. Again, the diagnosis for Staph aureus can usually be done within minutes of getting a culture, because the gram stain is going to be pretty obvious, but then also with other diagnostic techniques, we usually can have that answer within a very short period of time. So it's not hard to culture most bacterium, especially something like Staphylococcus aureus. So prevention is, it's going to require a specific type of hygiene. People who have Staph aureus infection shouldn't be made to feel like they are unclean. That nothing could be further from the truth. But people who are prone to having a lot of Staph aureus as part of their microbiomes that have had previous infections with this, they may have to go some extra effort there and use even prescribed types of medications when they are showering or bathing. Physahex is one that is commonly going to be advised to use for treatment, and being very aware that they are prone to those types of infections. So again, maybe using some very special kind of solutions when showering. Treatment is going to often be that they have to excise the area so that the pus can actually drain, and then with antibiotics is going to be needed as well. And because if it is MRSA, if it is resistant to many of the antibiotics that we know, it's usually going to require a combination of treatment. So vancomycin and maybe some sulfur drug as well. So a combination of treatments when you have something that is very resistant. Maculopapular rashes. Now, maculopapular is referring to skin lesions that can be slightly raised, flat to slightly raised kind of lesions. The more common ones that we think about these rashes are measles, rubella, and fifth disease. So we're going to take a look at each of these, and there's some pictures in here as well. Measles is something that many people have never seen, because in the healthcare profession, because we have immunizations against measles now. So thankfully, it's not such a common disease as it once was, but it used to be incredibly common. You can see how common it was back not that long ago before immunizations. But once the vaccine was introduced, then we started to see the mortality rates go down, the morbidity rates go down. People were not getting it. Immunizations do work, and we do understand that the causative agent of this is viral. So the virus is called rubella. And again, this vaccine has been incredibly effective. Unfortunately, we're seeing some people opting to not get immunization. So we have seen, even in the United States and other developed countries, pockets of epidemics of measles that are occurring in our younger children in schools and whatnot. And it's because the immunization is not being kept up with in those particular locales. So, if as far as a picture of what this maculopapular rash looks like, it is usually from really all over. This is going to be, and some of the signs and symptoms of this are typical flu-like symptoms. So, maybe pharyngitis, a sore throat, a little bit of a cough, some headache. The eyes can look, the conjunctiva is a lining of the inner membranes of the eyes. It can look a little bit inflamed. The eyes can be swollen lymph nodes. These are all very typical presentations of measles when it occurs. Copeland spots are white lesions in the mouth, and these again can be kind of diagnostic. Certainly the rash is something that is pretty diagnostic as well. Again, xanthomas referring to a rash, and it erupts on the head and progresses down to the trunk and extremities. It's pretty much all over. Some sequelae, some things that can happen after measles. It's because people can have all of this happening and it be self-limiting, the illness, but for some people that get measles, there will be sequelae or sequential after effects is what sequelae is referring to, and complications. It can go into pneumonia. It can actually, because of the person being so compromised, they can then get a secondary bacterial infection on top of it that can even lead to bacterial pneumonia following, which we know has an extremely high mortality rate, even with treating with antibiotics. And on rare occasions, it can actually even go into the central nervous system causing inflammation of the brain. And then leading to coma. This would result in permanent brain damage and or epilepsy. On rare occasions, it can actually even lead to subacute sclerosing panencephalitis. And what this is meaning is hardening or scarring of the actual brain that is 100% fatal. So even though we tend to think, measles used to be very common and it, many get over it. There's some that don't. And we understand that the immunization has saved not only millions from becoming ill and having these sequelae, but also saving lives because of the ones that, it was transmitted to that weren't going to make it. So this is very easily transmitted. It is probably one of the most highly contagious viruses that we know about. And we understand that, once someone has it, this becomes a public health crisis in that area, because anyone that has not been immunized, that has had an exposure, whatever, is very likely that they're going to actually potentially encounter this virus. It is incredibly contagious. So again, the measles, mumps, and rubella vaccine contains a live attenuated virus, and it can offer protection for decades. So it is recommended, it is part of the pediatric protocol for children, but it is also recommended as boosters if someone thinks that they may have been exposed and it has been more than 20 years since they have had protection from this vaccine. Maybe they are immunocompromised, and then it would be recommended that they also get a booster. Rubella Rubella is also a disease that we think of. It is from another virus, a different virus. It is actually called little red because it is a slightly milder version of rubella, rubiola, which was that caused measles. So it's referred to as little red. It can cause serious damage in a fetus. So if a woman has never had the vaccine for rubella, the MMR, measles, mumps, and rubella, or has never had natural immunity to this, then it is highly recommended that that female get immunized before deciding to become pregnant. Because if a woman encounters this virus while she is pregnant for the very first time and has the disease, she may not get very sick, but it causes serious damage to the fetus. So it is considered a teratogen, that word is here, a teratogen, or it has teratogenic effects. But a teratogen is anything that has the potential to cause harm to a fetus. So rubella, again, the illness itself is slightly milder than the typical measles. Typically, doesn't mean that some people don't get very sick and that it also has a mortality rate associated with it. But anyway, we have immunizations, so typically people don't see this too much anymore because of the immunizations and herd immunity. Again, there's a very kind of typical rash that we associate with this, and it can be associated with joint inflammation and pain after the rash. But the biggest real concern are in women of pregnancy-bearing years because of its teratogenic effects to the fetus. So it can lead to a miscarriage, or it leads to permanent multiple neurological defects. Oftentimes that is deafness. That's the most common thing we used to see before we had immunizations. We saw infants being born that were going to be deaf and or have some sort of physical retardation because of the mother having had the disease while she was pregnant. Some other sequelae, some other things that can happen are anemia, low red blood cell counts, inflammation of the liver, which is hepatitis, pneumonia, inflammation of the heart, and then even bone infection, so osteitis. So the virus is the Ruby virus, and again, it's a viral illness that has pretty much been eradicated from most of the populations because of immunizations. Not around the world, but most of the populations in developed countries. Again, we may see this change now that we have this sort of social thing that's happening now where people are not understanding how immunizations have actually protected our populations. So, this is something for everybody in the healthcare field to be informed about and aware of, and understanding how these diseases spread and how we can protect people from actually having these diseases. So, the next one we're going to talk about is fifth disease. This is also referred to as erythema infectiosum. That's another word that they use for that, but it is also sometimes referred to as slapped cheek disease. This picture looks like a little rosy-cheeked toddler, but actually it's even more pronounced than that. Typically, they could take on a very darkened appearance, the cheek skin, no matter the overall skin tone of the individual having it. The cheeks just become very, very darkened. Within a couple of days, there's typically a rash, and this rash is sometimes confused, because rashes can be a little bit confusing. So sometimes it can be confused with some other things, but fifth disease is typically going to run its course. It is due to a parvovirus B19. So this is a very, very common. There's no vaccine. There's really no treatment. It's usually mild. usually mild, and anyway, it can be diagnosed because of serology testing, looking for the antibodies that are there. So an indirect serology test, looking for those antibodies, indirect serology. So again, treating the symptoms while the patient is sick with this. Also, again, very, very common. Something to consider is that it has also been linked in women who are having the illness for their first time when they're carrying a fetus, and has been linked to teratogenic complications. Not as much as the rubella, but it's definitely been linked to that. Roseola. Roseola is again a very common disease in young children. This is referred to sometimes as the sixth, a maculopapular rash disease, the sixth one. But roseola is again a virus that can lead to a very distinctive kind of rash that usually happens after a very high fever. And this fever will come and go. It will last for days. Again, this history is really sort of indicative of this particular virus. So high fever lasted coming and going for several days, followed by this rash, and then it's usually a very easy kind of diagnosis to understand that this was roseola. Very common disease in young children. Now, everything we just talked about with those maculopapular rashes, measles, rubella, so all of those things we just talked about, they were from viruses. Now let's take a look at bacterial causes. We had started the conversation with Staph aureus, which is an opportunistic pathogen that we can often see boils and other wounds and lesions caused from Staph aureus. It's important to make sure we understand how to treat it. So if the Staphylococcus aureus, which is bacterial, was resistant to many of the antibiotics, we would need to know if it is MRSA. Not all Staph aureus infections are MRSA infections, but we need to understand that. Now let's look at a few other bacterial causes. Impetigo is very characteristic in how it presents itself. I think I have a picture. Nope, do I not have a picture? I thought I did. So I did. Oh, here's the picture. It causes kind of a crusty, golden, yellowish kind of lesions that are appearing on the skin with this. And it's very kind of diagnostic of impetigo. It's very contagious, so you can move. It will move from one area. If it starts like on the chin or at the nose area or on the knee, it will spread rapidly. It is usually caused by either Staph aureus or Streptococcus pyogenes, and or a mixture of the two. And very young infants, it's usually Staph aureus that's the cause. In older, it's usually Streptococcus pyogenes, group A Streptococcus. So Staphylococcus aureus in the very young, and the older, toddler, older, starts with Streptococcus pyogenes, but then Staph aureus can also take the opportunity to wreak some havoc there in that particular wound site. So the toxins associated with these two, the virulent factors, the toxins associated with these two, can be pretty serious, and it can lead to scarring. It can become even more systemic. So it's going to be very important that this be caught early and treatment started early. So again, this is bacterial cause of this, and we would want to make sure we treat it quickly to help to limit the spread, limit the scarring, but also limit the potential that this could become more systemic. So a very kind of common, impetigo is a relatively common infection, and so we need to be looking out for this. We know Streptococcus pyogenes, group A strep, can become more systemic, can lead to other complications from this that we think about with Streptococcus pyogenes. Cellulitis is inflammation of the soft tissues. So this is what this is referring to. So inflammation of the subcutaneous or soft tissues. Now, the concern with this is that it can be very fast in how it spreads. So again, diagnosing this pretty quickly and then making sure that we are treating with antibiotics with this. So some of the signs and symptoms are going to, and it can be anywhere. I have often seen it in the arm, on the arms of the legs. I've also seen orbital cellulitis, so it started on the face and the eye. That is even more of concern because of how close this is to the central nervous system, but we do want to make sure that we catch this early. There's usually going to be pain, tenderness, swelling, and heat. You know, all these things that you think about with inflammation, and also some lymph nodes might be involved in this. So it's going to be really important that we catch it before it can actually get to the bloodstream and then cause sepsis or septicemia. It is often, again, Streptococcus pyogenes and or Staphylococcus aureus. They take advantage of this. This is in healthy adults that we would be thinking these two. In immunocompromised adults or individuals, young, old, immunocompromised, it could be almost anything. So it could be bacterial, it could be fungal, it could be almost anything. So we're a little bit more concerned and more aggressive with the treatment as far as like broad spectrum. We're concerned with treatment for any of them, but definitely that. In infants, because we know infants have just recently moved through the birth canal, some women are carriers of group B streptococcus, which we said is Streptococcus agalactiae is the species name. Some women are carriers of this as part of their normal vaginal microbes, so they're going to have to usually be treated when they go into labor to reduce the numbers of this bacterium from their vaginal flora as before the infant moves through, the fetus moves through the vaginal canal. But because some infants do have this as part of their flora that they picked up, this is, if we see cellulitis in infants, this is a bacterium that we are also really thinking about. The good news is that Streptococcus agalactiae, group B strep, GBS, group A strep, Streptococcus pyogenes, and Staph aureus typically can be treated effectively with antibiotics. So we can typically, as long as we get to this early, we can get the treatment on board and typically have a pretty good outcome. Now, if somebody's immunocompromised though, and we're not sure what's causing it, then we're going to have to go with broad spectrum antibiotics and potentially even antifungals, and be more careful with that and following along with them. So typically too, for cellulitis, there may have been a history of a trauma, but maybe not. Most people say, no, I don't remember bumping this area that is now inflamed. I have no real memory of doing anything like that. And it's usually no break in the skin. So this inflammation happens quickly, the swelling happens, the heat happens, the redness happens, the pain, and there's no obvious reason that is happening. So again, an indicator that it might be cellulitis. So if it has gotten to a point that it's really progressed, then IV antibiotics, certainly with that orbital cellulitis that I have seen, that's going to require IV antibiotics, not just oral antibiotics. And or depending on the overall health of the patient, you may have to decide to put them in-house, like admit them to a hospital, do IV antibiotics, and even sometimes surgical debridement might even be necessary in the extreme cases. Scalded skin syndrome is because of Staphylococcus aureus. Staphylococcus aureus. It has an exfoliating toxin that can actually lyse skin. Lyse means to split skin. Lytic, split derm skin. So we know it has that virulence factor that it can do that. And it's called scalded skin syndrome because of Staph aureus, Staphylococcus, because that's what it looks like. It looks like the skin has just been scalded away. And when we see it, we can see this in infants sometimes. This has actually been known to cause an outbreak in neonatal units. in pediatric units, so it's most often affecting newborns and babies, but it can affect older children as well as adults. So if you see that scalded skin kind of appearance, and along with fever and pain and all of that, it could really definitely be because of Staph aureus. Now, scalded skin appearances can sometimes be yeast infections as well, so whatever, but they present differently. All right, so these are just some of the, as I said, some of the places that we see them. Vesicular or pustular rashes, so little vesicles that are fluid filled. That's what a vesicle is, a fluid filled type of situation. So these types of rashes, we think about things like, we sometimes call them pox, right? Because these lesions contain fluid. Chickenpox is very common and mostly benign, but does have a mortality rate associated with it. Again, we're seeing less and less of this in our populations in developed countries because of immunizations to chickenpox that have been now available for more than 2 decades. So now we're seeing less and less of it in our younger populations. But it's a pretty typical kind of rash that presents itself. Now, chickenpox is caused by a virus, and it's called the human herpes 3 virus, human herpes 3 virus. The virus name is varicella zoster, so herpes zoster virus, and again, fairly common in the population. Smallpox is a disease that is, if you can see this picture here, a very much worse kind of pox type of illness, but it's also a much higher mortality rate associated with smallpox, and it has been eradicated. The variola virus caused smallpox, and it was eradicated from the human population in the late 70s, in 1977 actually, after an 11-year worldwide campaign of going out with volunteers and immunizing populations around the globe. Then we eradicated smallpox, a wonderful accomplishment for humanity when that happened. Because we still have this virus, though, that we have kept in laboratories, in particular biohazard for laboratories around the globe, we still have to be thinking about it, because if that virus were to ever get out of one of those laboratories, it will spread incredibly fast, because all of these actually are viral illnesses or respiratory borne, really easily spread viruses, and spread quickly through populations. Again, chickenpox, even though it does have a mortality rate, and it can cause scarring, and it can cause some complications that last, it's usually not going to. Most people will get over it. They may have a few scars from the pox, the very minor pox compared to smallpox. But smallpox is different. This has a significant mortality rate, and we'll talk about that in just a second. And if there were any indication that someone thought that they had a patient that had smallpox, this is considered a public health crisis and law enforcement crisis, because the only this would cause such unrest and so much death around the globe. But let's look at chickenpox, which is very, very common. Not as common now because we have immunizations, but typically the rash is going to begin, it's usually on the trunk that it starts, but then can move on to other areas as well. The fever, there's going to be some fever, some flu-like symptoms again. Incubation time is long, usually about 2 weeks, about 14 days, up to 20 days it can be. Again, incredibly contagious during that time because it is respiratory borne. And then as long as the skin lesions, the little pox, are weeping fluids, there's still a chance of spreading that. So the lesions can number as few as a few hundred to just a few to hundreds. So there are some people who've had chickenpox who didn't even know they had it because their parents didn't tell them that the parents may have never known. They may have had such a mild case of it with such few pox lesions that it went undetected. And so some people actually have natural immunity because they had it, and or they've had the immunization and then have immunity because of that. So anyway, you can look at some of these things about chickenpox. Herpes zoster. So in the herpes family of viruses, again, it's the human herpes virus 3, called varicella zoster. That's here somewhere. I don't know. It's here somewhere in your notes. Varicella zoster is the virus that is the name of that virus. If someone has had chickenpox, that virus will tend to move along. And it says it here in these notes. It's going to move along a nerve ganglion, a sensory nerve ganglion, and lie dormantly there in the body for the rest of the life. And for many people, they will never develop shingles. But for about it's estimated about a third, you'll see, of people who've had active chickenpox, it's another reason to get immunized and not have it, will develop shingles sometime in their life. Shingles is going to be a reactivation of the virus along that sensory nerve, and it will cause a trail of vesicles that are incredibly painful because they're along the nerve. So it's going to cause this nerve pain while it is activated. So some people really have a very hard time during the outbreak of their shingles that can last weeks. So what is going to happen with them is that eventually this trail of vesicles would clear for most, but there are a few people who, once they have shingles, just a few, and remember, only about a third of people who had chickenpox will get shingles, and then a few of those that get shingles will develop what's called post-herpetic neuralgia, which means after the herpes zoster outbreak, shingles, varicella zoster, after the outbreak, there will be continued nerve pain. So it can last for months, it can even last longer than that. And depending on what nerve it followed along, like you can see the umbilical region here, so this is on the anterior trunk of this person, but it can actually go into, it can follow a nerve into the eye, and it can really end up causing blindness, and it can end up causing paralysis along those areas. So depending on where the virus ends up coming back out along which nerve, we think about how aggressive to be in trying to help with those symptoms during that time. Some people actually have to take, because of the chronic neuralgia, the chronic nerve pain, have to take anti-seizure medication to try to just alleviate some of that nerve pain. So for many patients, especially elderly patients who are keeping the post-herpetic neuralgia, it's the beginning of the end for them, because the pain is so severe that it interrupts their sleep, interrupts their appetite, interrupts the way that their immune system functions, and you can almost map their decline after a very serious shingles outbreak. So, this can be certainly a very serious kind of sequelae. Again, the human herpes virus, HH3, it's also referred to as varicella zoster or herpes zoster. And anyway, so that's describing exactly how it progresses. Now we have a vaccine. So hopefully we also have a vaccine, not just for chickenpox, but for those of us who had chickenpox, and we know we have the potential of someday, there's a risk of someday developing shingles, then we can get a shingles vaccine as well. So now there's a chickenpox vaccine and a shingles vaccine as well. Smallpox, as I said, we have eradicated this. It is a real golden medal for humanity that this happened, that we eradicated this in the late 70s. These pox, very, very different than chickenpox. So even people who survive it are typically scarred in a, a very obvious kind of way. And these, even if you survive the initial smallpox infection, the scarring would be sort of horrific, actually. So you can see this, a picture of what someone, again, the last known human case was 1977. So that's actually, it has been eradicated. Variola is the name of the virus, variola. It's highly virulent, which means that, the mortality rate is significant. And a diagnosis of even one case by a medical team would mean that this would be treated as a health and law enforcement emergency. So no more personal choices. This would be quarantined down. So, because that's how it would change humanity as we know it. Most people now alive on this planet have no natural immunity. Some of us that are old enough, we actually got immunized. We got a vaccine against smallpox, but obviously that vaccine campaign ended in the late 70s, and now anybody born after that, which are most of the population now, would have no immunity and would be really ripe for this virus to wreak incredible havoc around the globe. Again, very, very contagious. Okay, so that's smallpox, and we can take a look at that now. So now I want to talk about large pustular rashes, lesions, and when I say large, they can have a huge margin. One of the ones that you may never see, depending on where you practice or where you may end up living, but one is from a protozoa known as leishmania. Leishmaniasis is the disease, leishmaniasis. Leishmania tropica and brasiliensis or species are two of the species. These are going to, this can become systemic, so it does have a mortality rate associated with it. But typically when someone has a lesion like this, they're going to end up seeking some sort of support from the medical community. This is a zoonotic disease, which means that we get it from animals, transmitted among that, and it is transmitted by the female sandflies. It is endemic in the equatorial regions, so there would have had to have been some history of travel to the equatorial regions because it is endemic there. These sandflies are endemic. And as far as there's no vaccine, the prevention is going to be being aware of, when you're in these regions, to avoid certain pests like the sandfly. So that's really the only prevention. So this is leishmaniasis, and again, it causes a very kind of typical rash, and it is from a protozoa that is actually transmitted through the sandflies. Now, anthrax is a disease that is caused from a bacterium. That bacteria is called Bacillus anthracis. Bacillus is the genus, anthracis is the species, and cutaneous means that it's on the skin. Now, systemic anthrax, where you've inhaled some of these spores and it's causing systemic disease, is incredibly fatal. Cutaneous anthrax does not have as high a mortality rate. We typically do not see it as much as we used to, but that's because people are very aware of these types of lesions. It causes a necrotic lesion. Necrotic means the tissues are dying, so they're going to have to be debrided. And in this black scarring lesion, because of the tissues dying, believe it or not, it's also killing the nerve endings, so it can actually be painless. But again, when people have these kind of lesions, they usually seek medical attention, so it's going to be diagnosed hopefully pretty quickly and taken care of with antibiotics fairly quickly as well. If it's cutaneous, again, as long as it hasn't become systemic, it can typically be treated. And people who work with hides of animals, since the spores are in the soil, these spores from Bacillus anthracis are in the soil. People who work with animals that have hides like wool and whatnot, these spores can be there, and it can actually, if they have any opening on the skin, then they can actually have these kind of lesions. So again, the testing is usually serology testing, direct or indirect serology testing, culturing. You can use PCR techniques, which is going to end up getting you the answer fairly quickly. If left untreated, it can be as fatal in as many as 20% of the cases if left untreated. Again, most people who have this kind of necrotic lesion are going to seek treatment, but if left untreated, it has a significant mortality rate. There is a vaccine that is recommended for people who are in high-risk groups, but again, if this becomes systemic, then the mortality rate goes up tremendously. So that's anthrax. Now, mycosis, which we know that means fungal infections. Mycosis means fungal infections. When we think about the fungal infections of the skin, these are caused from dermatophytes. There's a group of fungi that collectively are referred to as dermatophytes. Ringworm is one of the more common situations that we see. All of these infections that are caused from fungi, and you can see some microscopic slides of the fungi, these start with the disease characteristic starts with the term tinea. Tinea actually means worm-like, but it was derived from that because sometimes the infections on the skin can almost look like they're being caused from a worm. There's these circular looking kind of lesions. So tinea capitis of the scalp, barbae of the beard, tinea corporis is ringworm, tinea curis of the groin, so pedis, foot, athlete's foot, and you can actually undiem. This is the nail bed. So fungal infections have to be treated with antifungals. You know, we've learned about chemotherapeutics and how to be effectively treating. You have to be treating what's causing the actual illness. So in this case, it's a fungus. It needs antifungals. Antifungals have very low therapeutic indexes. So because we understand that fungi are actually eukaryotic, their cells are eukaryotic, just like our own cells are, so the therapeutic index is pretty low. You want to know what you're doing when you're treating with an antifungal. Luckily, in cutaneous infections, you can often use an antifungal cutaneously, so you're not having to take that antifungal orally. If the illness is deep enough or serious enough, they sometimes will prescribe not just a topical antifungal ointment, but also a systemic one, knowing that the therapeutic index is low and being very careful with that drug. If you're taking an antifungal drug systemically, orally, you usually are going to be having to check liver and kidney functions along as you go. Or you're just going to, or they're going to be monitoring it really very carefully. So when we think about tinea infections, we said there's a group of dermatophytes that actually can lead to very, these fungal infections. These are some of the genus names that you think about: trichophyton, microsporum, epidermophyton. These are some of the ones. Oftentimes, the presentation is such that they won't even do a culture because they're going to, just from the presentation, it's pretty obvious that it's fungal. So instead of really worrying about so much getting a definitive diagnosis with culturing a fungal culture, they can sometimes just do the treatments and then they're going to see about that. So superficial mycosis. Now superficial, meaning that it's not the deep tinea infections here that you're seeing here. Superficial, like tinea versicolor, where you're seeing a very superficial type of infection is usually from yeast. Tinea versicolor is a yeast called Malassezia furfura. Malassezia is the genus, furfura is the species. So again, topical kinds of antifungals will work, and if you can get away with that, then that's what you want to do. Now, we have, almost every human has this yeast on our skin, but it's only when the skin has become compromised in some way. So either too much sun exposure, maybe too much chemical exposure due to sometimes harsh even cleansing agents, that kind of thing, it can actually occur. So, so it's fairly common, and not superficial ones are not so difficult to treat with topical and resolve. If it goes untreated, then it can leave behind. It's not really scarring, but it can take a long time for that to look like it resolves. Now, of the eye, the eye has so many built-in defense mechanisms. Our conjunctiva is that very vascular membrane that surrounds the lids, and even the sclera of the eye, the white of the eye, all but the cornea, which is that clear, the cornea is that windshield of the eye, the clear coat above the iris, the colored part of the eye. So all of this, there's so many built-in protections. We secrete aqueous fluids, oil, and mucus that have antimicrobial enzymes. We have tears that are, our biggest defense is actually our tears that are continually being produced by these lacrimal glands washing across the eye. Any excess is going into this lacrimal duct. So we have tears that have to be continually produced, cleaning the eye. And most of the time, if somebody tries to culture the eye, do a culture from the eye, it will look like your eye is sterile. Now, maybe it would make sense to you that it's not really completely sterile. There are some microorganisms that transiently are in the eye, but our eyes are very, very much protected. They're so much protected, they have what's called immune privilege. Immune privilege, you should know what that means, is actually, and it sounds counterintuitive, but what immune privilege means is that for your eyes and your central nervous system, your brain and your spinal cord, it actually favors reduced immunity. Now, why would that be? Is because we think of immunity as being protection, but you really don't want your eyes always reacting to, reacting to anything that it might encounter. So you don't want your eyes always like having mucus and fluids coming to the eye, excess fluid and whatever to the eyes. So actually there's a reduced immunity is what immune privilege means. There's a reduced innate immunity, because what we know is that diseases, infectious diseases, part of the way that they can do damage is that they themselves have virulence factors that are damaging our tissues. But they can also do damage by causing your immune response to be such that now the immune response is causing damage. So the eyes actually are protected against that, which is a catch-22, but they are kind of protected. They're not going to, if they didn't have this, probably almost every day of our life we would have some mucus draining from our eyes. That's the truth, and we need the eyes to remain clear because we need to see. Okay, so that's what immune privilege actually means. There are some normal skin microorganisms that we think about that can be present in the eyes, but it's very, very much a reduced amount. Now, when we think about conjunctivitis, that's inflammation of the conjunctiva. It causes red-looking eyes because the whites of the eyes, you'll start to see like vessels. So sometimes people refer to this as bloodshot eyes when the conjunctiva is inflamed, but certainly it's fairly common to have conjunctivitis. The most common cause of conjunctivitis is allergies. You want to write that down, it's allergies. The next most common cause are viruses. Usually adenoviruses is a group of hundreds of viruses that can lead to a little bit of the eyes becoming inflamed looking. So the most common allergies, the next most common is viruses. And then the least most common is actually due to bacteria and or other causes, but bacteria. So the common what people call conjunctivitis is typically pink eye. In infectious diseases, we only call it pink eye if it's bacterial. Viral and allergies, we don't really call it pink eye. We just say that you have some conjunctivitis. But anyway, let's take a look at some of these causes of serious, not allergies, not usually viruses, but serious causes of conjunctivitis. In neonatal, so newborns, in neonatals, the thing that you worry about really most is bacterial Neisseria gonorrhea, bacteria chlamydia trachomatis, and the virus herpes simplex, human herpes virus 1, human herpes virus 2, herpes simplex 1, herpes simplex 2. These can lead to blindness in the neonate. And the reason that any newborn that is born in a clinical setting in the developed country will get a drop in each eye of erythromycin or some variant of antimicrobial is to prevent blindness due to these two. We don't really have a way of those drops won't be effective against herpes viruses. But what typically happens in developed countries is if the mother has any indication that there might be a herpetic lesion or outbreaks, then the neonate will be born by C-section instead of vaginally. So that would be the only way to really prevent that from happening. But you can see in a bacterial conjunctivitis. Bacterial conjunctivitis isn't a clear, watery, they say clear, watery exudate. In a bacterial conjunctivitis, it is cloudy, it is mucousy, and it causes incredible swelling and pain and lesions in the eye. It can scar the cornea, which can lead to blindness. In the world today, the most common, and not in developed countries, but still in the world today, the most common cause of blindness is going to be due to chlamydia trachomatis. That's in developing countries and whatnot. As I said, in developed countries, that drop in each eye of the neonate right after birth has prevented this. In the United States, herpes, human herpes 1 and human herpes 2 is still the leading cause of blindness in the United States right now. Now, if it's not a neonate, you can get bacterial conjunctivitis if you're an adult. You can definitely in all other age groups. It's typically due to Staphylococcus epidermidis, which is part of the normal flora in the skin. Typically, this is fairly mild. Now, if it's due to ones that are more virulent, like Streptococcus pyogenes, Streptococcus pneumoniae, Haemophilus influenza. Haemophilus influenza and Streptococcus pneumoniae are really the most common bacterial causes in other age groups other than babies. These are the most common. And so this is why when someone has conjunctivitis, they often get antibiotic drops, even if their conjunctivitis isn't bacterial, even if it's viral. They're going to typically get that. Now, you can still get these two that we just talked about in babies. If you have those infections, you can auto-inoculate yourself from the genital region to your eye, just touching those particular regions, genital regions. And it doesn't have to be just genital, because you can have gonorrhea in the mouth. So taking that from there to the eye can also happen, or through sexual activity. So these can happen too in adults, but it's not usually very common in adults. These are the ones that you think about in other age groups. There can be fungal, it can even be protozoal. When we think about protozoal, we're often usually thinking about acanthamoeba, which is an amoeba that we see when people have contact lenses. And they can, from just contaminating their contact lens because acanthamoeba is in tap water, or not treating them as often as they could, can be transferred to the eye, and fungi can as well. Again, these can be highly contagious, so physicians often prophylactically give an antibiotic, even though they know that most cases are allergies or viruses, but they'll prophylactically give an antibiotic just to prevent a bacterial infection, from happening, as far as like that goes. Keratitis, this is actually, again, can lead to deep eye tissue scarring of the cornea. So herpes simplex virus is one that is probably, again, the most leading cause of blindness in the United States. I don't know about other developed countries, but I would assume that probably it is also in other developed countries as well, the leading cause. Now, again, this amoeba, acanthamoeba, that can cause keratitis. This is due to contact lenses. This is a free-living amoeba in tap water and freshwater lakes and that sort of thing. So it has been associated with less than rigorous hygiene when you have contact lenses. So people with contact lenses have to be really careful. Now, this slide, I love these slides because they put everything we just talked about in a nutshell. So I hope that you enjoy hearing about, well, or at least listen to skin and eyes, and I'll see you on the next one.